Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Angelini Pharma.
Hello, I'm Marco Mula. I'm a consultant epileptologist at St. George's Hospital in London. Welcome to this activity. Are we undertreating depression in people living with epilepsy? It is my pleasure to be joined today by my friend and colleague, Leigh Sander, Professor of Neurology at Queen Square Institute of Neurology in London. Welcome, Leigh.
Hello, Marco.
Our topic today is depression in people with epilepsy. There is lots to say about this and whether we are doing a good enough job. But in order to keep it focused, we will answer questions against the clock. Are you ready, Leigh?
Yes.
So how common is comorbid depression in people with epilepsy? Let's see if you can answer in 1 minute.
I will do my best. So, epilepsy is a common comorbidity amongst people with epilepsy. Indeed, depression features in at least a quarter of people, but this may be differences according to the syndrome. Some epileptic syndromes, this might be even higher. For instance, the temporal lobe epilepsy might have a much higher prevalence of depression. So we have to be always very, very attentive to the problem because, comorbidities have a major impact on the life of people. And depression impacts quality of life, impacts a number of things. So we should be always on the lookout for this. But depression also is a marker for a increased risk of epilepsy in people that never had epilepsy. So it is really a common thing and we need to be fully aware of this. So, Marco, now that we know that epilepsy is a common problem, can you tell us about depression, which is also a common problem, how close they are related and why you think this is?
So there are obviously a number of reasons why people with epilepsy are at increased risk that are both biological factors related to the key areas in the brain that are involved, but also a number of psychosocial reasons, because even today epilepsy is a highly stigmatized condition that is associated with a number of social limitations, the loss of the driving license, for example. And for kids with seizures, overprotection by families obviously don't help with the development of self-esteem. There are now good data in the basic science areas showing that a number of biological mechanisms relevant for depression are relevant for epilepsy as well, as low serotonin levels and hyperactive HPA axis. So we need to consider depression as a symptom of many epilepsy syndromes along with seizures. So, Leigh, what do you think? We are doing a good enough job for our patients with epilepsy and depression? This is quite a difficult question, so I'll give you 2 minutes.
Yes, we could be doing a better job. And I think indeed we should be doing a better job. In the clinic, when people come, the epilepsy clinic, we often just count the seizures. And that's not good enough. We should be trying to establish what's going on with the person in terms of their mood, terms of their, quality of life. And so asking questions about mood and other issues is important. We should actively try to identify mood, depression, cognitive comorbidities, and because if we can act on them, we can improve life and be doing a better job. We should be having a low threshold for making referrals to people in other specialties like colleagues and neuropsychiatric colleagues, because often an intervention can make a difference. So we need to remember that. But we should also be always be worried about the people's mental state. So before starting any drug, before making a major change, it's important that we record this, because sometimes things change. Psychiatric comorbidities have a major impact on well-being, and working on them can help. Improving mood can even improve sometimes seizure outcomes. People are more able to cope and can have less. And we should remember as well that people that have cognitive issues, mood problems, they have a higher risk of, for instance, psychiatric comorbidities, which increase the risk of things more dramatic, like, for instance, the risk of SUDEP. So it's important that we are always in the case, making sure that we provide a full treatment to the person, very joined up, and we should never be complacent. Always ask the question, always act on it. So, Marco, it's my time to go, and I will give you 90 seconds this time. How can we clinicians screen for depression and people living with epilepsy?
So now for adult patients with epilepsy, we have a number of validating screening instruments that can be used in everyday clinical practice. And clinicians can choose one of these screening instruments depending on whether they are simply more familiar with that specific scale, or because they are more involved in the outpatient setting or inpatient setting, or simply because one is quicker than the other, or because some of them are validated in multiple languages and they run a very international clinic, for example. But the most important point is that it is important to use validated measures in people with epilepsy, because screening instruments that are even well known for depression may have a threshold score that is not valid, may not be valid in people with seizures. And it is important to use these screening instruments annually, or at least at every consultation, and documenting the notes in order to see how they change over time, in order to risk assess and monitor interventions.
So it's very important that we actually use validated questionnaires for screening.
This is a very important point. But for another important point, you may remember the issue of suicidality with anti-seizure medication. So what do you think? Do you think that anti-seizure medications cause suicidal thoughts and behavior? You have 90 seconds.
Yes. Yeah, these are concerns, and we often have this question. People talk to Dr. Google, and they will see that many antiepileptic, anti-seizure medications will have a black box about suicide. So we need to be well aware of this. I think that the concerns are sort of a little bit, let's put it, exaggerated. And if you look back, they based on the FDA analysis, the very famous FDA analysis that came out over 10 years ago, where they looked at a big number of people with epilepsy, and indeed over 40,000 patients were included eventually, but only about a quarter of these patients had epilepsy. So the people that were in this had chronic pain, they have post-traumatic, there were loads of them, well, most of them were war veterans. And what they have shown is that there was a slight increase in the number of people anti-seizure medications than taking placebo. And this was not really related so much to epilepsy, to the drugs, but it was more related to the background condition of the people. So this created a whole concern that has been exaggerated. Yes, of course, we should be always well aware of this, but I think that the concerns are a little bit out of hand.
This is a great answer, Lei. And actually, suicide is a complex and multifactorial phenomenon in the general population. And obviously, having epilepsy makes patients at increased risk of developing suicidal ideation in general for a number of different factors. In a recent study, for example, we showed that in people with drug-resistant focal epilepsy, after starting any sort of intervention, 1 in 5 develop anyway some depressive symptoms, and 6% may even develop suicidal ideation. But this obviously doesn't imply any causality. It is because of the many different mechanisms involved that are obviously complex in people with epilepsy and not completely understood.
Yeah, that's a very important point that you make. Depression can be a dynamic process, and so is suicidal ideation. People that have it one day may not have it tomorrow, independent of the drug. So, Marco, can you tell me, and you have 90 seconds without hesitations, repetitions, or deviations, what can we do for people with epilepsy and depression, starting now?
So we can do a lot. And we need to distinguish between intervention for patients in order to increase awareness and educate patients and families about this symptom in people with seizures. But it is important that neurologists and all healthcare professionals increase their skills and knowledge about clinical presentations of depression, and become more aware about side effects of antidepressants, especially SSRIs, pattern of interactions with anti-seizure drugs, and how they can use in people with seizures, because depression in people with epilepsy tends to respond very well to any sort of very basic intervention.
Yeah, that's a very important point, Mark. We need to be always very aware, and we need to be making sure we make it into referrals. We should also know a little bit about the drugs, particularly the ones that could have a sort of psychiatric side effects. So I would really think that we could do better, but we should be always trying to improve to make the life of the people we look after better.
You are very right. But how can the healthcare profession improve communication both with patients and between each other? You have 90 seconds.
Yes. I think it's very important that we have a very clear line of communication with patients. We need to establish a clear therapeutic partnership. We should be talking to patients in terms of risks of developing problems, the risk of seizures, the risk of medication, what could happen in terms of, the mood may change, someone may lose the job, mood may change. We should always try to tell people it's not their fault. That's part of being human. We always think it should be us. We should be signposting patients to services, patient associations, support groups. Very often they will have good support documents, information. We need to remember that mental health should not be a taboo. We need to be talking to people and to be able to, as I said earlier, to signpost them to help. Healthcare professionals, it's a little bit different. We should be always trying to provide a joined-up service. We should be calling a multidisciplinary team if we have any problems. And because, at the end of the day, everyone's objective is to help the patient. And we should be doing this in the most joined up way we can.
You are very right. There are specific clinical presentations like patients that are acutely suicidal or with psychotic symptoms that should never be managed by neurologists, though, and they should always be managed in psychiatric settings. And this is why it is so important to have partnerships and clinical pathways for these patients. So, in conclusions, I think that yes, there is a lot that we can do, but we do tend to undertreat patients with epilepsy and depression. It is important to be aware of the problem and how to recognize, because depression is common. 1 in 4 people with epilepsy have active depression, meaning symptomatic depression in the last 12 months. We now have a validated screening instrument to risk assess and identify our patients, and we have treatments available. What we need is obviously for a neurologist to improve their clinical skills, to develop specific expertise, and from a patient association to inform their patients, to develop material, leaflets to educate their patients. So thank you, Lei, for this very nice discussion about epilepsy and depression, and thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.